We're going to start on time today. Look at that. Okay. I believe this is where we left off last time. And we're going to take a little diversion from straight orthodontics for a minute. We're going to talk about a couple other things. We're going to finish up this lecture, then we're going to go into some, if we get time, we'll go into some of the whys behind why we expand. I'll also go over with you how my philosophy on expansion has changed over the last 10 years, mostly owing to more current research and being able to see visually on a cone beam what the jaws are doing when we treat. But this was a straightforward, phase 1 type case, some anterior crowding, and we could talk about the case, but if you look closely, you can barely see it because the flash kind of made them hide a little bit. But there's some developmental white spots on these anterior teeth, and we know that these happen from time to time. And what are the solutions that you guys know for this? Like, if a kid comes in and they have some developmental white spot type of thing, like what are the solutions? Okay, so Icon is one of them, and that's what we're going to talk about. Any other solutions? Tell me more. Like, so whitening, I'm familiar with that. Like, you whiten everything, and the white spot, yeah, it gets whiter, but then it goes back to where it was, and the rest of the tooth's whiter, so you can't see it as much. But what's the bleach and seal? What's that? So you're using sodium hypochlorite to bleach the external of the tooth? And it's just like an in-office treatment kind of thing? And that results in whitening it or camouflaging it, or?
I mean, it's the seal through the resin, so that it just it's similar, but it's just like more resin.
Interesting. But it's not etched, it's bleached. Yeah. Is that like is a company selling that, or is that just a procedure technique? Huh. Yeah, send me some info on that. That's interesting. I never heard of bleach and seal. I mean, the only time I've heard of bleach used is like root canals or internal bleaching, things like that. But I've never heard of like bleaching the external of the tooth in order to correct something like that. Does it work good? All right. Yeah. Microabrasion, right? So microabrasion concept behind that is right, removing some of the external layers. At the end of the day, if there's something developmental and it's still there, most likely it's in some deeper layer of the tooth, right? Because if it was in a superficial layer, as soon as hygiene was improved and calcium could get in there, then it would correct itself and it wouldn't be a white spot. So, I mean, the fact that there is a white spot means that the lesion is in some ways deeper than is accessible to the normal external environment. So you have to access it some way. So go through this case. Orthodontically, we basically gave options. I mean, there's not a ton of dental crowding. There is a jaw size discrepancy. You could do an expander. You cannot do an expander. And you can decide what you would do on the case. But again, I want to show you more of the result of this. So we ended up doing an expander. We ended up doing partial brackets in the front. And now you can see without the flash, you can see those lesions pretty well. And you can see the depth of and the extent of where those were. I mean, not orthodontic white spots, but just developmental white spots. So this is Icon for those of you who aren't familiar with it. I don't know who this guy is, but he did a cool video on it. So we'll watch that real quick. On the centrals, you can see that's also more of a developmental type of white spot. So first step, of course, you're going to isolate. Hydrochloric acid, a little bit stronger than our normal phosphoric acid. Multiple cycles. Sometimes you can combine that with microabrasion. Put in some pumice. That's the resin, unfilled. Cure it. We ended up doing some actual global or pack, I don't know what kind of composite it was, but you can do some pretty good work covering those up if with the right tools, right? So let's look at these, and this is the way that we did it. So you can see here we just used a curable gum barrier, and we started to etch. You can see as those teeth are dried off, you can see a lot more of those lesions. And as we etch, the idea is we're going to expose more and more of that underlying deficient tooth structure. And so we'll go back and forth, we'll etch, we'll rinse. You can see we did a slurry pumice, so if you add some pumice to that hydrochloric etch, then you'll have essentially a microabrasion that can help get through those outer layers of enamel a little bit faster to access the deeper layers. The alcohol preview is the most important step of this process, in my opinion, because this shows you what you're going to get. So it wets the tooth, the alcohol goes into those areas of the tooth that are deficient, and it will show you if it's going to treat out well with the actual resin. And so you'll go back and forth with this preview step and etching until you're either, one, not making progress with the tooth anymore, like it's just you etch again and it looks exactly the same as it did the time before, or B, you've gotten rid of all of the white spot areas and then you're ready to infiltrate after the alcohol step. So we have the alcohol, that looks pretty good, most of it's gone. So now we'll go ahead and get the infiltration going. Again, make sure you're prepped well. Obviously, if not, you'll burn the gums and they'll heal, but you want to avoid that. So this is another case here. These are more orthodontic white spot lesions here, as you can see. They're also more fresh. You can tell the hygiene wasn't great based on those photos. And this was after the icon treatment. And then here's one more. You can see kind of a more developmental on these. Actually, some brown lesions that were surprisingly came out with the mostly came out with the micro etching process, so that was good. And then one more here. You can see there was an actual divot in the distal facial of the maxillary right central incisors, so that was later filled by her dentist, but the rest of the more developmental white spots were taken care of. So, biggest things, you cure it twice because it's an unfilled resin. So you're going to, infiltrate the tooth. It's going to go into the tooth as deep as it can. You're going to cure it. It's going to shrink significantly because it's unfilled. So then you do it a second time. All those little micro cracks and fractures that are there now because the composite cured, you then fill again and then cure again. And at that point, the shrinkage should have a minimal effect, and that should be stable. I would also warn you, don't have your patient go eat something like curry or something very colorful right afterwards because it can pick up stain. It'll go away if it does, but we had one patient in dental school and her teeth were almost neon green for a couple days, so it was pretty wild. So be careful with that. Have any of you guys used Icon? How many of you have actually used it? Yeah, so 4 or 5 of you. Yeah, it's a great product. I was using it quite a bit, and I went to a bunch of dental offices and tried to teach them how to do it and actually do it. It's really difficult it's time consuming. And it's hard to bill for, and so I think that's why it's not more popular than it is. The material itself is pretty expensive, but it is a great option for patients who want a minimally invasive option for white spots, either developmental or otherwise. Okay, so we're going to kind of work through some concepts that we have gone over already. So this is obviously a case. Let's look at this one together. When you look at this case, let's start diagnosing it. And let's start creating our problem list, and let's start creating our effect list as well. So when you guys look at this case, what are you seeing? What kind of a crossbite? Okay, so unilateral, anterior, and posterior. So are you more worried about the unilateral anterior or the unilateral posterior? I know he has both, but what's that? Okay, posterior. Why are you more worried about unilateral posterior? Okay, it can indicate a transverse deficiency. That's true. So could a bilateral posterior. So could a normal bite in the posterior. But yes, that's true. It does indicate. Okay, so tell me more about that. Growth asymmetry. Why would you be worried about growth asymmetry with the unilateral posterior crossbite? So you want to determine right away if there's a shift or not. Now, looking at this picture, you don't know if there's a shift or not. But looking at the face, what are you seeing? What do you notice about the face when you look closely? Chin is a little off to the left side. I mean, you can definitely see the midline off to the left side. And when you look here at the facial photo, if you get really picky, you can see the chin is off to the left side as well. So that's going to be a good question to know. If there's a shift, is that a good thing or a bad thing? It's better, right? That means that he still hasn't grown that way as much. He's still shifting that way. So if we correct that crossbite, he will shift back. If there's no shift, that means that growth has already been asymmetric. And even if you correct the crossbite, which you should still do, so it doesn't get worse, you're going to have an asymmetric face. The lower chin is going to be off to that side. That's not going to self-correct. Okay? So anterior crossbite. What are we worried about with anterior crossbite? What are the effects of that? Okay, trauma to the teeth, okay. In what ways? What types of trauma? You talking like chipping the edge of the tooth off? Okay, that's one type of trauma. What other type of trauma? Let's say there was a type of trauma that you might not even see until they were 40 or something. What would that be? I mean, it could be, yeah, possibly some type of root resorption, not super common. What would be more common? Yeah, perio, right? So when you look at where these teeth fit together, and you see this one being pushed facially, this one being pushed palatal, that's going to affect the position of the root. So up here on this tooth, you might see that we start to lose bone. You might see recession here. On this tooth, I mean, it could push the tip of the root all the way out of the bone, and or when that tooth is brought forward, could cause recession. So again, that's something that is not as easily detected. When you're looking at a cone beam, you can see much better where the roots are in relationship to the bone and how much of a risk that is or not. But again, when we're talking to parents, they're not going to understand, they might understand what you're talking about if you say they're in crossbite, but they're not going to understand what that means. And so we want to be clear with what those risks are. So now from a crowding standpoint, where are we at from a crowding standpoint? Let's start with the bottom. Any concerns on the bottom? Not really, right? I mean, you can see we've got, seems like plenty of room for the teeth. They're erupting in the areas that they should be. We do have a diastema between the central incisors, so there's some space there. We got a couple millimeters. The laterals may be a little bit small. We have our C's, D's, and E's if you go back up, and we talked about when we're measuring crowding, if you have the C's, D's, and E's, then you should be okay, canine first premolar, second premolar. So is this a big crowding issue per se? Not really, right? So today, well, let me just ask you, let's look at the bite here. You can see a little bit more edge to edge. Actually, I'm going to go back here. Let's talk aesthetics. What do we see aesthetically now that we would want to be different later, possibly? I mean, besides the chin being off, we want to get that back on, right? If we can, right? But what's that? Yeah, what about the incisal display? Yeah, and not a lot of the maxillary teeth, right? So what could that indicate? What is that? Why is that? Why is that the case? Do you think? Are you thinking like maybe like the teeth are kind of holding the upper jaw from coming down? Looking at the Seth, what's a normal lip at rest? Assuming the lips are at rest, which is not a good assumption, but in here it looks like they are. But what's a good lip at rest? How much incisal display should they show lip at rest? 2 to 3 millimeters, right? How much do we have here? Like 0, right? So we're maxillary deficient. Other things that back that up, you can see the mandible, actually the mandibular plane angle looks pretty normal, but look at the occlusal plane, it looks more flat. So we have this maxillary deficiency where the upper teeth have, and the anterior maxilla has not come down as much as would be ideal, and that's resulted in a lack of incisal display, all right? And that in combination with the maxilla that is more narrow compared to the mandible, you're not having, you can see buccal corridors, but they're mostly the bottom teeth, right? So you're not really seeing much of the top teeth at all. So from a long-term standpoint, anything we could do to broaden that upper jaw, and as we widen it, it's going to come down and forward, is going to be beneficial facial aesthetically, okay? And you can argue about if it's better for the teeth long-term or not. We'll go over, if we can get through it today, some additional data that would say that it is more beneficial for the teeth as well. So looking at this case, I mean, what would you guys do if this were your patient? How would you treat it? Expander, okay. So you could do different types of expanders, right? In this case, I would usually do a bonded RPE. You can cover all the teeth. And what else would you do? Would you need to do anything else? Mm-hmm. So if you use like a Hyrax, you're going to have some sort of way to open the bite up as well. If you use a bonded RPE, the bonded RPE itself is going to open the bite up because it's going to be over the occlusal surfaces. All right, and then you might need something to push those teeth forward. Maybe partial brackets, maybe arms on the expander that you activate and push them forward, however you want to do that. And that's how I would treat this case today as well. That's not how this case was treated. This case was treated before I got to the practice. And so this case was treated with upper Holly with the finger spring. Now, I don't think that that's a bad treatment plan. I think that that is a legitimate option to treat this case. And if the parents had concerns about they didn't want expansion for some reason, then I think that that's a fine way to treat the case. You're still going to prevent the possibility of anterior trauma. There seems to be enough room for the teeth overall, so they should come in. And we likely will be able to compensate and get the teeth to fit together later, which is what you'll see. So that's how this was treated. So this is 4 years later. You can see here the teeth did come in. A little bit of crowding. All of them came in. None of them are impacted. All right, lower midline is slightly to the left. What does that likely tell us about his growth? Well, you can look at his face too. So likely he had some asymmetric growth, right, before we were able to get in and correct that. That's why both the pedo and the ortho boards will ask you, like, you know, when should you correct a unilateral posterior crossbite? And what's the answer? Yeah, as soon as it's diagnosed, right? I mean, and the pediatric dentist in the room, like, oh, let me ask, how many orthodontists have corrected this in a 4-year-old or a 5-year-old? Yeah, like, probably none of us, right? Because we never see those kids, right? So as a pediatric dentist, you either need to learn how to correct it or learn how to refer when you see it, right? Because you will literally be able to save these kids, you know, asymmetric growth for the rest of their life. What other complications are there from that? Hard to say, but you would think if the jaws hold the teeth and one of them's off compared to the other one, it's probably not as good, even if aesthetically it doesn't make a big difference. You can see here, did anything change with the maxillary incisal display, really? Not really. We're still showing a ton of teeth, right? We haven't moved the bones, so we wouldn't expect that to change because that's the way he was already growing. He did have some trauma. You can see he had some bonding on the upper centrals and doing some tug-of-war or something like that. You can see that jumping the crossbite, his profile looks a little bit more normal. And so this was a 12-month total treatment time case. And again, I think this is an acceptable result. The teeth fit together. The jaws were never corrected, so to speak. Expansion was never done. And there's a lack of incisal display. The buccal corridors, again, you're going to see more of those lower teeth. He's probably going to age a little bit faster than if we were able to get that upper jaw down and forward. But this is how we used to always treat cases, right? Today, 100%, because the mindset back then was like, do the least amount possible to get to this, to get to teeth, straight teeth fitting together, okay? So now my mindset is I want to get the jaws as ideal as possible, as early as possible. Yes? Finger springs. Yeah, literally just tip the teeth out. Yeah, it went all the way back. Yeah, yeah. I've never done one like that. I was actually impressed that that's how they did it. So, yeah, I mean, if I wasn't going to expand, I probably would have done partial brackets or, you know, at a minimum, like some type of a quad or something, like just to get those teeth moving. But yeah, but they did it with a Holly and finger spring. So I was impressed. Okay, so let's look at another case here. Similar situation. So we have, except it's just an anterior crossbite here. So what are you seeing in this case? Let's diagnose it. What are you worried about? Let's start there. What are you worried about from what you see and why? He was afraid of the records technician. That's why. No. All right. So what do you see? What are you worried about? What's troubling? What's concerning? Okay, anterior crossbite, and you said what central? Which one?
Right central.
The maxillary right central. Okay, why are you worried about that? Okay, potential trauma risk. Agreed. Anybody else worried about any other centrals? Lower right central. Why? Right. So even without a CBCT, you can see that that tooth is getting pushed forward, you know, pretty much out of the bone. All right. It's hard to tell where the root of that maxillary tooth is, but likely that's getting, you know, pushed back. You could potentially, if it gets pushed back far enough, it could actually tip the apex of the root out of the bone. I've seen that before. All right. So what about our crowding assessment starting on the lower? Again, we'll look at the pano in a minute. But what about our crowding assessment starting on the lower? Looks okay, right? What about on the top, just looking at the teeth? I mean, really not bad, right? You've got CDEs, you have laterals, you have extra space, you got some space between the centrals. What about our aesthetics? How do our aesthetics look? I mean, obviously he's smiling funny. Well, he's not going to smile any bigger than this, right? I mean, we got a full smile here. And we're seeing, you know, some of the top teeth. You're still losing the top teeth as you get more toward the posterior. again, there's our potential recession we want to watch out for. Let's look at the pan. Okay. This pan is, I think this pan was somehow like magnified in a weird way or taken at a weird angle or on the wrong setting or something, because this looks way more crowded than we saw in his mouth. Here's our Ceph. We can see maybe a little bit more lip at rest than the previous patient, but maybe not a ton more. Okay? So what if you talk to this patient and there's no airway concerns at all? You know, you mentioned like aesthetically, oh, you know, maybe the upper jaw is a little bit more narrow, could come down and forward, show a little bit more of the teeth. They're like, yeah, whatever, I don't really care. How would you, what would be your recommended treatment at that point? Okay, yeah, so it'd be pretty straightforward, right? You could put some brackets on the teeth, disarticulate, bring that anterior tooth forward. You've solved the immediate risk for trauma on the lower right central incisor. You've gotten the teeth fitting together, and he should have all of his teeth come in, right? Yep, you could do it with a finger spring. With a Holly retainer, right, you could add an anterior bite plate into that, so that's kind of like two birds with one stone kind of thing. So you could do that. Actually, we did neither of those things. What if this kid was severe sleep apnea, was reporting like he never feels like he can breathe through his nose? You know, parents are concerned, like they're like, hey, you know, like we like his smile, you know, he's a good-looking kid, but we'd really, you know, like we kind of feel like it's, you know, like if it would like maybe be broader, it might fit his face better, things like that. Well, now what are you leaning toward? Yeah, right? And isn't it interesting? Because the case didn't change, right? It's the circumstances around the case. So again, it's like, for me, with cone beam, it makes this a lot easier because now we have an objective piece of data that we can point to and just say, hey, look, you know, like this is, you know, quote unquote normal. 200 years ago, everybody had an upper jaw that was wider than the lower jaw. Doesn't mean you have to, but like this is, we're starting from ideal and working backwards. But you're going to have these cases that are borderline. In this case, we actually ended up doing just an Essex retainer. I think it was 2 Essex retainers, an A and a B, and we just pushed that tooth forward. He had a little bit of a slide forward. So as that tooth came forward, he basically dropped back a little bit, and that was corrected fairly simply, about 6 weeks, and then he just wore it at night. So again, not a huge deal, and not every treatment for every patient is going to be the same. It is based on their desires and also the extenuating circumstances, the whole entire complete picture. So if you're not asking those questions, then you're going to be trying to make a recommendation based on more limited data. Okay, let's get through this one here. What do we see here? What are you worried about when you look at these photos? What's that? Okay, ankylosis of the lower D's and E's. And why are you worried about that? They're in for occlusion. And why are you worried about that? Huh? Yeah, you could have space loss for sure. What else? Why else are we worried about that? Another way to ask that is, what bad things happen if we just leave it? Okay, so delayed eruption of the permanent teeth? Okay. Okay, yeah, that would happen. Why is that a problem? I mean, if they eventually erupt. Heard a lot of things, and I know at least some of it was really good. So we talked about super eruption, right? So if you have teeth that are not erupting, then the opposite teeth can super erupt. Depending on if that's unilateral or bilateral, that could cause A, some weird leveling in the top, or B, a maxillary cant, right? If one side erupts more than the other side. Okay. What else? What else could happen long term? Okay, you could have a bony defect, right? So depending on, you know, where if they have permanent teeth or not, and or how those permanent teeth erupt and or when these come out or don't. Best case scenario, you know, you get these out and the permanent teeth come in. Now, seeing how ankylosed those are, is your guess that there are permanent teeth underneath there or not, and why? Probably not, and why? Yeah, right. You would think that, like, even if there was a tooth under there, like, with how far up the rest of these teeth are, you would think that it would at least be getting loose or something by now. But you won't know until we see the x-rays. But we have, you know, basically this upper left side, you can see how ankylosed that is. You can see these bottom teeth. And if we leave that, especially if there is no permanent tooth underneath, then the discrepancy is going to get continue to get worse. She's obviously still pretty young. I think at this point, 10 years old. There's going to be a lot of vertical growth left. And by the time you do end up extracting something, if there's no permanent teeth behind there, you're going to end up with bone loss and in a situation where you might not even be able to put an implant in later without significant grafting. So let's see. Some of these baby teeth did have permanent teeth underneath them, and some of them didn't. So you can see on the top, also worth noting, the left side is ankylosed much more than the right side, and or ankylosed earlier, right, on the upper left. Okay, so we'll see if that affected anything as we go through this case. You can see we have permanent teeth for the lower Ds. We are missing lower premolars here. Here's our vertical and our Seth. So what would you do in a case like this? And why? Any ideas? Well, what are our options? Let's go through them. We can leave it. We talked about why that might not be a good idea. Okay, so let's eliminate that one. We're not just going to leave it and watch it. So what are our other options? Extract. Okay, you could extract them. All right, you could extract all of them. All right, so let's say we extract all of them. Most likely, that would speed up the eruption of the first premolars and the upper second premolars, right? So that'd be okay. What happens if we extract the lower E's and there's no permanent tooth underneath there? What do we worry about? Yeah, spacing, space loss, tipping, and you'd already mentioned, bony defect, right? It's really hard to get an ankylosed tooth out, right? So, I mean, unless that surgeon is super duper careful, you're probably going to lose some bone just with the extraction itself, okay? And so maybe not ideal to extract them, at least the lower E's. So what other options do we have? You could build them up, okay? So building them up, that corrects potentially the potential for super eruption of the opposite teeth, right? So that's a good thing. Does it do anything for the vertical discrepancy as she continues to grow? No, the bony discrepancy is going to remain the same because the tooth's going to remain where it is, right? So that does help with kind of the growth and development of the upper jaw and the upper teeth, so to speak, because you can manage the super eruption there, but doesn't really help us with the bony defect and or the long-term vertical discrepancy in the bone, vertical bone levels between those teeth long-term. So what else? Anything else? What's that?
Cornectomy? Just took away.
Let's talk about that. So let's check this out.
Ankylosis is a dental term for a condition where a primary tooth loses its normal ligament connection to the bone and becomes fused directly to the bone. This is a fairly common occurrence and is most often seen with lower first molars. When a primary tooth becomes ankylosed, 3 problems result. First, when the tooth root fuses to the bone, it no longer grows out at a normal rate with the other teeth. Because of this, it appears submerged compared with the other teeth. Second, the upper teeth need the lower teeth for support. With the tooth submerged, the opposing upper tooth grows out of the socket and also loses its normal alignment. The third and more serious problem has to do with the roots of the ankylosed tooth. About 50% of the time, the roots of the ankylosed tooth fail to normally dissolve as the permanent tooth grows in, and the permanent tooth is blocked out of position. The solution to these problems is the eventual removal of the ankylosed tooth. We'll work with you and your child
Probably
to
super
determine
high-tech
the best
in the 90s
timing.
when they made that video. Okay, so that was extraction when there's a permanent tooth underneath. All right, but if there's not a permanent tooth, decoronation is an option. So anybody want to tell me what decoronation is or how it works? What's that? You cut off the crown.
2 millimeters below the bone.
And why do you cut it off 2 millimeters below the bone? And why would you get overgrowth if it was 2 millimeters below the bone, but maybe not if it was not 2 millimeters below the bone? What's that?
Science. No vasculature over, like, no, we can't build a scaffolding on that because it's going to go there.
Yeah, does bone grow over enamel? No, never, right? That's why we have like enamel and teeth and everything's attached below the enamel, right? So if there's even the very smallest portion of any enamel at the cervical of this tooth, then the bone is not going to be able to grow over it. Additionally, if you have 2 millimeters of bony exposure, then everything's telling the body that this area needs to be bone, okay? Now, this procedure is very technique sensitive because you think about that. I mean, it could be multi-rooted teeth. This is obviously at least 2 roots. And 360 degrees, and you're exposed, and you have to like try to make sure that the tooth is actually cut away. When the tooth is ankylosed, there's not much of a PDL, right? So it's hard to see, like, where's the tooth, where's the bone. So it's definitely a technique-sensitive procedure, but that's what we sent her out to get. So decoronation of the lower E's and extraction of those other teeth, okay? Well, you can see we didn't extract the upper right E. I mean, maybe we should have. It probably was a little bit ankylosed, but we didn't. Or maybe we shouldn't have. We'll see. I'll show you later. But when you look at just this pano from post-treatment, what does it look like as far as, did we do a good job with the decoronation or not? On which side, and why would you say that? What are you seeing? Left side looks good, okay? So over here, kind of looks like everything's, you're not really seeing much in the way of roots or tooth above the bony crest. And then what about the other side? Yeah, looks like there maybe is a little bit of tooth sticking out here, okay? So probably should have called the surgeon and said that at that point, right? Probably should have called him and said, hey, can you get them back in? A little worried about this. We didn't, so this was a 1.5 years later, okay? So you can see the normal response on the left side, bone has covered up that root. That's what that should happen if you do a proper decoronation. You can see on the right side, it didn't, right? You see there's probably some bit of enamel there, and that's triggering, hey, the bone shouldn't go over that, and that didn't fill in, okay? So that's why when we send out for decoronation, again, you want to make sure that it is removed 2 millimeters below the crestal bone and leave the rest of it in there. So we sent her back, and we said, hey, please finish this decoronation, just take more of the tooth off. And when she came back, the tooth was gone. And you can see the difference in the vertical defect between the left side and the right side. So not ideal, all right? So she's getting a little bit older. Permanent teeth are coming in now. You can see the rest of the permanent teeth have come in those other areas, okay? So let's talk aesthetics now. Do you feel like these ankylosed teeth affected the aesthetics? And in what way? Okay, so she's been a little bit narrow. So that's a good question. Does ankylosis affect the widening of the bone? My gut would say no, because the bone grows independent of the teeth, and it's hooked to the bone. So, I mean, it should grow out with the teeth, but or it should grow out with the normal bone growth. All right, what else aesthetically? What do you see? Okay, so the teeth are somewhat collapsed in, and maybe, maybe that had something to do with not having support of those teeth, right? When the occlusion is supporting itself, it'd be harder for those teeth to tip in. Tongue posture could have something to do with that as well. What else aesthetically do we see? Say that again. Does she have a cant? Okay, so did you guys see a cant? What side do you see is canted? What side's more inferior? So her right side, left side of the photo, is more inferior than her left side, correct? So it's kind of like slanted this way. Are you looking at top or bottom?
Sorry, I was looking at the top. I just thought you meant, I see what you mean, more, it is what I was picturing.
Yeah, so we're looking at the same thing. Left side being more intruded, right side being more inferior. So does that add up with the ankylosis that happened? That left side was much more ankylosed than that right side, right? And so like when I talked about maybe it's a good idea to leave that right side in, well, maybe it was, right? Because if that was ankylosed, maybe that was holding that side back a little bit and give the left side a chance to catch up once that tooth was removed. But obviously it didn't catch up completely, okay? So this ideally would have been identified earlier. Those the primary teeth would have been extracted earlier. Decoronation would have been done earlier. Now, as an orthodontist, who here has seen a 5-year-old and detected an ankylosed primary tooth and sent it out for decoronation? I haven't either. I've been practicing 10 years, right? But as pediatric dentists, you guys got to be looking for this, right? I know you look for ankylosis, but usually when we say we look for it, it means that we found it, right? It's like, oh, there it is, because I can see that something's off, right? But you can tap the teeth. I used to, like, it took me a long time to develop, I guess, an ear for tapping ankylosed teeth. But once you get it, it's like you can hear, and not 100%, but the two things you want to check: one, tap the tooth, see if it sounds different. Two, check for physiologic mobility, right? So normal teeth have a little bit of physiologic mobility. They should be able to move a little bit. If you put like the back of a mirror on both sides, you should be able to move it a little bit. And so if you're like tapping all the teeth, if that's just part of your exam, and you're hearing thuds on a certain tooth, and you're trying to move it and it's not mobile, I'm not saying extract that on a 5-year-old if the occlusal plane isn't affected. But what I'm saying is, like, put it in your chart and pay attention. And like 6 months later, like, check it again and see is it the same? Because as early as you can identify it, the better. As soon as you identify it, send it out for treatment, the better, the less problems like this they're going to have. Okay? So this is where she was. You can see also she never formed wisdom teeth, so that complicates things a little bit as well. If she had wisdom teeth, we could look at, protracting the lower teeth with a TAD or something like that. Here was the airway. This was progress treatment. Basically our plan was to recreate spaces for eventual implants. With the bone being thin in those areas, you're going to see how the result of that was. So you can see here we have some recession on the lower first premolars. And the teeth, we had a difficult time even uprighting the teeth in the back. And so, like, maybe the space for the implants is not as ideal as it could be. And you can definitely appreciate her smile is a little bit pulling more on the left side than the right side. But if you look at the facial and kind of ignore the asymmetric lip pull, you can see there still is a slight cant with the right side being more inferior compared to the left. And so this was the final pano. You can see here what looks like some sort of cemento-osseous dysplasia going on between the lower anterior teeth, so we had to send her out for that. But certainly next time we send off for a case, we want to be a little bit more specific about making sure that that bone is 2 millimeters below, and also, following up, taking that pano afterwards and seeing, is the result what we thought it was. Yes?
On a different note from ankylosis, now would you expand the expander in the beginning?
Yes, absolutely. Yeah. So yeah, and again, we never really. Let's go back. Yeah. So I mean, good result overall, but considering the circumstances. But yeah, in my opinion, and again, you could measure it out, but you can see that the lower teeth are compensated quite significantly still in order to match the smaller upper jaw. I think it's worth considering. I don't think that's a terrible idea. Or honestly, you could. Here's the challenge. So when you protract, and this happens especially with adults, but even with kids, when the bone is that knife edge, when you protract, it's not that you can't get the tooth there. So I mean, especially if you did like some microosseous perforations, like these teeth would come forward. But you're seeing the result of teeth being moved into an area where there's not as much bone, right? You're going to have recession, and so like, could you bring those forward? Almost 100% yes. Would you have to extract the 5s to do that? No, you could bring it forward. You just wouldn't have much occlusion on the back teeth. They could still wear retainers. They could get an implant back there later if they wanted to. So you could leave the 5s on the upper. You could bring the lowers forward and just finish class 3 molar, or you could extract the 5s, finish class 1 molar. But I think you're going to have long-term perio problems, especially on this side. And then on the left side, remember we left the roots there, which again is what you want to do. In order to preserve the bone and allow the rest of the bone to grow vertically as those teeth erupt. So if you were to extract the tooth later on, you're going to end up with a bigger defect versus the decoronation. So if you do decoronation, then the question becomes, can you mesialize that tooth through that root that's still in the bone down there? And I would think that would not be easy, right? Because the PDL will resorb bone, but it's not necessarily going to resorb root. So if you were trying to mesialize it, you would have had to make that decision, probably earlier. Try to do an atraumatic extraction and bring those teeth forward as quickly as you can. But I still think you run the risk of long-term recession, and that may be more of a risk or a complication than just placing an implant later with some bone grafting. So it's a good thought, and definitely you can, it's an option. I think it's a good option, but that's why we didn't do it that way. All right, let's look at this case here, and let's diagnose this case. What are you seeing? What are you worried about? Okay, so there's definitely more crowding in this case than the cases we've looked at so far. What crowding are you most worried about at this point? Lower anterior. Okay, so you can see, and why would we be worried about crowding in the lower anterior? What bad things could happen if we don't do anything with that? Okay, more crowding, impaction, possible permanent tooth removal, maybe root resorption, maybe perio gets a little bit more thin as those teeth get pushed more and more forward. All right, and then on the top, what's going on with the top teeth? We have a space in between the top teeth. Isn't that good? Why isn't that good in this case? Yeah. Well, yeah, so why is there likely a space? What's happening? Yeah, something's probably happening with the laterals, right? Maybe there's not enough room for them. They're getting blocked out, and those roots are starting to move forward. Let's take a look at the pano. We can see here we are missing lower right 5. You can see the extent of the crowding. The laterals look a little bigger in this case, not a lot of room for them. As they come down, you see those central roots have gotten out of the way. You can see the tips of the canines are a little bit past the apex of the lateral, which is good, but still not all the way in the safe zone here. You know, hopefully the diastema would close as those laterals try to come back down more. And then we have our missing lower right second premolar as well. We have to come up with a plan with. Here's our Ceph. See a little bit of a downward-backward growth pattern. A little bit more of a high angle case here. All right, so what would you do in a situation like this? Any ideas? What do we want to do? We want to prevent these canines from impacting, right? We want to make room for the teeth to come in, and we want to make sure we have some sort of a plan, or at least monitor those lower incisors to make sure we're not pushing those out of bone. Expand. Expand the upper, make that wider, makes more room for the canines. Maybe consider extracting some primary teeth early. What are we going to do with that missing lower right second premolar? What do we want to do with that? Going back here, we've got no wisdom tooth yet. Okay, it's not ankylosed, so no rush or hurry there, right? Okay. So this was a year later, post-expansion. You see we've made more room. Diastema is closed up. We went ahead and extracted D's at this point. And you can do it either way. I mean, the literature, if you look at it, most of the literature is going to show you to extract the primary canines first, and or the primary canines and first molars at the same time. Typically, we'll extract the first molars first. And the reason for that is we want to have this premolar get ahead of the canine more. As this drops down, we tend to see these canines drop back. You can see at this point, though, the tip of the canine is still, it's almost crossing over those lateral roots. So we're still not out of the woods yet. So we went ahead and RX'd the upper D's, followed by the upper C's about 6 months later. And we'll keep going here. And then what happened to our lower right second molar? Primary molar? Yeah, it ankylosed, right? So again, ideally we would have caught this a little bit earlier than we did. You can see here it's already 2.5 millimeters below the occlusal plane. And so if we would have caught it earlier, we could have had it extracted earlier, but we do see now that we're actually forming wisdom teeth, so that gives us more options. So this is where she was at phase 2. You can see that we did have that primary tooth extracted. You can see that those molars mesialized and moved forward, and you still have a decent ridge here. If you close that space completely, you may have a little bit of recession, or more likely to have recession on those teeth at some point in your life, but that may be an okay compromise, all things considered. If I were to treat this case today, I would likely do just that. I would close the space, put a tat on that right side, mesialize those molars into a class 3 on that right side, upright those roots, and allow the wisdom tooth to come in. I was in the practice when this case was treated. I didn't treatment plan this case, and we weren't doing mesialization at the time. But in hindsight, look at how thin that ridge actually was, and or at least a year and a half later it was. So would it have been a good idea to close the space? Maybe. That's probably the way I would approach it today, and just hope that that tooth brings as much bone as possible there, or maybe even consider having some type of graft done there at the same time. At the time, we went ahead and opened the space for an eventual implant, and that was where we finished. Again, she's probably going to have that wisdom tooth pulled eventually, so again, it's kind of Was that the best idea or not? I don't really know.